Very good. I'm glad I didn't get too much further into that. Let me go ahead and introduce Erin. I'm really excited about today's topic because we all know how important nutrition care is. So I'm going to stop chattering after a brief introduction. I'd like to introduce Erin Era, who is a registered dietitian nutritionist for the Veterans Administration in Northeast Ohio healthcare system. And that's in Cleveland. And she's been working with ALS patients for 13 years. And she actually helped assist the clinic at the Northeast Ohio Healthcare System Veterans Administration become a certified center of excellence. So that's a really way to go, Erin. That's a lot of hard work there. She's spoken nationally on ALS and nutrition, has publicized on the topic, and she's also with the MOVE program, which is a weight management program coordinator for the administration. So Erin, thank you so much. I'm going to pull myself off screen and let you have at it. Thank you so much, Erin.
Okay, thank you for having me. And I just wanted to mention, we were the first VA to be a certified center of excellence. So it was really exciting at the time. So I just have a couple pictures. This is our facility in Cleveland, and then this is a view of Cleveland from our facility. I was looking at like stock photos, and I'm like, oh wait, I have a good one. So, so glad to be here. So today I'm just these are my objectives, is to explain the role of the registered dietitian on the ALS team, identify nutrition-related issues that may occur with ALS patients, and then discuss the nutrition intervention options for patients, and hopefully give you all a lot of practical information. So this is just part of our team. This is our Ice Bucket Challenge, of course, back in 2014, and then that was probably our biggest walk to defeat ALS team for the Cleveland VA. Okay, so a couple things. So as far as on the interdisciplinary team, of course, nutrition is really important. Things to kind of remember that I try to kind of remember is really to honor patients' preferences and desires. And, it took some time and practice to kind of step away and realize that the most important thing is what the patient wants. So that is one culture change we've had, at the VA, is going more towards a whole health approach to care, and starting with what the patient wants and then going from there. And I'm probably going to say veteran a lot. Hopefully I don't, but I'm just so used to working with veterans. And veterans, just, I'm sure many of you know, but veterans are twice as likely to develop ALS. So they're at an increased risk. So things I'll do on the team is I'll assist with helping the patient obtain adequate nutrition, hydration, ideally preventing or minimizing weight loss. I do typically recommend tube feeding for most patients, but of course we'll talk about that it's completely up to them if they want to have a feeding tube placed. Trying to maintain safe nutrition, especially as speech recommendations change or consistency of the diet will change. But really the biggest goal is to help patients achieve the highest quality of life possible throughout the course of disease when it comes to nutrition and eating. Okay, so the assessment. So these are things I look at. I get a weight, height, take a look at appetite changes. If they're having early satiety where they're getting full quickly, if their length of meals are increased, if they need assistance at meals, if they're experiencing fatigue at meals, because those of course can all impact eating habits. Getting good information as far as swallowing and chewing goes. Getting some social history, so ability to obtain food, so food insecurity, looking at resources and support. And then getting a good diet recall, especially a good baseline diet recall. So when a patient comes first to the clinic, seeing what they're currently doing. And then I do reassess that at each visit. what they're doing as far as meals, snacks, timing, fluids, if they're taking any oral nutrition supplements or tube feeding. And then we do prescribe a good amount of oral nutrition supplements for patients. And we'll also take a look at laboratory tests and other procedures, especially the swallowing evaluations. Okay, so this is just a little expanse on the diet recall. So I typically do a 24-hour recall. So it's hard for people to remember what they ate much back more than a day. So trying to get a good descriptive. So what time of day you ate, how much you ate, what you drank, what you snacked on, anything if they experience fatigue at meals or if they notice that it's taking them longer to eat meals. Sometimes that can be helpful, like, when if you're sitting down with a family or a spouse, you may notice that you are finishing, or the patient may notice that they are finishing a lot later than they with the rest of the group. So sometimes that comparison. Fatigue with meals. So, I ask if they're, at the end of the meal, are you really tired, or are you noticing that you're not finishing a meal because it's too much work? Of course, needing for assistance with meals. So checking in on that. If they're avoiding any food, sometimes I'll ask, I typically will ask them, are there any foods you're avoiding because you're afraid of choking? Because that can kind of help give me an idea of what foods they may be having issues with. If they've made any changes with diet consistency on their own, or if it's been recommended by speech. And then seeing how they're doing as far as compliance goes with diet recommendations. So these are, I wouldn't say this is an exhaustive list, but I jump around a little bit with this, but common nutrition problems with ALS. So a big one is malnutrition. So it occurs in about 55% of patients with ALS, and it impacts survival. So, there's a lot of different factors that I'll go into that may contribute to malnutrition. Oops, I skipped ahead. Okay, but difficulty swallowing, and I'll expand a bit more on most of these listed. An increase in metabolism. So they think about 60-70% of patients with ALS have an actual increase in their metabolism in addition to other factors that may make it difficult to get adequate nutrition. Oh no, sorry. I lost the screen. Let me just make sure I can find it again. Okay, there we go. Talked about difficulty with self-feeding. I think I said that twice, actually, it looks like. Decrease in appetite for various reasons, increase in saliva, constipation, a very common issue I run into with patients, and then changes in body composition for various reasons. So malnutrition. So about half of ALS patients typically will lose more, 2.3% of their usual weight at the time of diagnosis. They've already lost that much weight, and then 25% have lost even up to 7.8. So just to kind of give you an idea from my perspective, typically anywhere between 5, especially 5 to 10% is pretty significant for weight loss, especially unintentional weight loss. So we keep an eye on that. So patients with a weight loss of greater than 5% at time of diagnosis are twice as likely to pass away earlier versus someone that had less than 5%. And that's really hard because a lot of times a patient doesn't know that they have ALS, so they're not, it's hard to prevent that weight loss. It can negatively impact the diaphragm function, so makes it more difficult to breathe with malnutrition. Can have an impact on immune system, and patient. Of course, I mentioned an increased risk of death, and even more if you have malnutrition during the disease. So really trying to prevent malnutrition is going to be important. So body mass index. So I know body mass index gets a bad rap, but we know it can be a tool that can be helpful in predictions. So, a lot of people are looking at their body mass index if they're trying to lose weight. So the different obesity categories we have, normal weight is green, blue is underweight, yellow's overweight on this chart at least, and then this pinkish area is obesity class 1, obesity class 2, obesity class 3. So in the ALS population, there's it's actually more beneficial to be in this low obesity range. Okay. So those patients that have extra weight when they go into, at diagnosis, that's actually beneficial for them. With that being said, I wouldn't typically recommend like someone trying to get to this level if they're down here in normal, but definitely trying to prevent weight loss. And I know I have patients that have difficulty with this, especially if they've never had extra weight in their life, or they are, maybe prior to diagnosis, they were trying to lose weight. Also, the change in body composition with oftentimes, losing muscle mass in the extremities. And then oftentimes you will see fat mass distributed around the waist. So especially like we have veterans that some of them were in pretty good shape, and then when they have this change in body composition, it can be upsetting for them. So I try to help them, find a good happy medium where they're okay maybe with a little extra weight, but it of course can vary. So when it comes to difficulty swallowing, I just want to go through a few definitions because it can be a little confusing sometimes. So dysphagia, you may hear that. That's the medical term for swallowing difficulty. Aspiration is when those ingested foods enter the airway and the lungs. Silent aspiration is when they enter the airway, but there was really no cough, no throat clearing. So we really, you may not notice that happening. And then aspiration pneumonia is when that food or beverage collected in the airway collects bacteria and can lead to a lung infection. So that's really the goal, is to prevent the aspiration pneumonia. So working with a speech language pathologist can be really helpful in this aspect. Swallowing screens. Some simple strategies that can be helpful is, sitting upright while eating, taking time, eating slowly, small bites or sips, and just kind of paying attention to swallowing function. And then there's feeding difficulties. So of course, with upper extremity weakness, there can be difficulty feeding oneself. So, this is an example. This is an OB, which can be a very expensive item. But something like this could be helpful, or having, family, home health assistants feed the patient. But talking to an occupational therapist can be helpful, especially when it comes to difficulty with self-feeding. So this is what I call this is the Eat 10 swallowing screening tool. So this is a screening tool I will typically utilize for patients with ALS. So it's 10 questions, or I should say statements, and it was developed by Nestle, and it was validated for the ALS population. I go through this with patients, the 10 statements, and then I have them rate them on a scale of 0 to 4 to kind of help me determine what could be a better intervention. So a couple of them I'll read real quick. My swallowing problem has caused me to lose weight. One says swallowing liquids takes extra effort. Swallowing solids takes extra effort. Swallowing pills takes extra effort. So typically with an abnormal score of 3 or higher, that's when, which isn't hard to get, especially for ALS patients, that's when I would recommend they have maybe a more formal swallowing evaluation or meet with a speech pathologist. But this can be a nice screening tool to be helpful in finding swallowing issues. Because I did like a quality improvement looking at this versus just asking someone if they have swallowing difficulty. And I was finding that a lot of people would say no, but they would be abnormal with this screening. So it's able to kind of look at different aspects of swallowing than just asking in general. So again, some more swallowing tips. So food sticking. So may make you feel that can be an issue, may make you feel like you need to swallow again. With this, moistening foods with gravies, sauces can help move it through the passageway better and prevent it from sticking. Taking those smaller bites and sips can help with control with swallowing. And then alternating sips of liquids every couple bites may help, lubricate and get the food moved to the stomach. So a lot of medications, this could be something, can be crushed and added to like yogurt and pudding to make it easier to swallow if you're having difficulty with pills. But of course, asking your doctor or pharmacist just to make sure it's okay with your specific medications. So taking a look at diet modification. So these are the International Dysphagia Diet category. So it was recently changed in the US. So this was our previous different diets, and then they changed it to make it more international. So you may get recommendations as far as which type of diet, if there's some abnormal swallowing with food specifically. So there's regular and then soft and bite size. I'll talk a little bit more in detail. There's minced and moist, pureed, and liquidized. Okay, so giving some examples of if, recommended a puree diet. So that would be like pudding, pureed oatmeal, breads, meats. So basically like, in a food processor to a mashed potato consistency. Hummus is pureed fruits and vegetables. So a food processor, if recommended a food processor, that can be really helpful. Then there's, I guess I should start on this side. Regular, you would start with is, no issues. And then going to, and it doesn't always go in this order, but this is kind of a typical progression. Sometimes people go right to puree depending on their level of swallowing difficulty. So soft and bite size. So soft and bite size, you want to avoid certain like nuts, seeds, sometimes really hard foods, stringy foods, but these are typically foods that you can tolerate. When it comes to meat, maybe focusing on like a ground meat or a pretty tender meat, or using gravies and such. Minced and moist, so it's a bit even a bit more soft, and you also see some extra things added to make it moister. So like a lot of sauces are used in this, and then we talked about the pureed. As far as liquids go, so thickening liquids can protect your airway when swallowing becomes more difficult, because it helps give better control. So there's a lot of different thickeners that can be used. So there's powdered thickeners, there's liquid thickeners, but this is, this is why it can be helpful, because it helps with control and slowing the speed of that fluid. So these are the consistencies. So there's thin, which is just regular, slightly thick, which I don't see that very often as far as speech recommendations. I typically see mildly thick, which is like equivalent to like a nectar consistency, moderately thick, which is more like a honey consistency, and then extremely thick is going to be more like a pudding consistency. Okay, to kind of give you the idea with that. And then energy balance. So energy balance is a huge factor that is impacted in many different ways related to ALS. So patients with ALS typically have increased energy needs. So it just takes them longer. It's more effort to do things in their everyday life. So that's one. So they're putting a lot of energy into their everyday activities. An increased difficulty in breathing. So it takes a lot of calories actually to breathe. So, when you're having difficulty breathing, or it it can be a challenge. And then fasciculations if they're having contractions of muscles, um, and then also, like I said, there is just an increase in metabolism in general with ALS, and probably contributed by a lot of these factors. And then there's the other side of it, the decrease in energy intake. So if someone's having difficulty chewing, I don't see chewing as much of an issue, but more so swallowing. If they have a fear of choking, they may limit food in, kind of unintentionally. If it's taking them longer to finish their meals, it may be just more effort. They may stop eating sooner and not eat as much, or if they're having physical challenges getting that food, that beverage to their mouth. Breathing difficulties may lead to less intake, of course, if it's, having a hard time catching their breath in between eating. And then, so sometimes restricting fluid or food because they don't want to go to the bathroom as much, which is definitely not recommended. And then, of course, constipation, that discomfort from constipation makes one not want to eat as much too. And then, of course, depression could be a contributing factor. Um, I can think of an example. I had one veteran, years ago, and he had a hard time asking for help. So, and I see this with a good amount of veterans. So he didn't really have too much support, and he wasn't asking for enough help. So he was alone a lot, and he couldn't bring that food to his mouth. So that was a big challenge. I think one of the things we worked on was just asking for that help. These are some resources. So you may have seen the ALS Association resource, which I definitely use that. There's this easy to swallow, easy to chew cookbook that I actually provide our patients with, but that can be a great resource. It's written by two speech pathologists and one dietitian. I don't get any kickback from anything here, so just letting you know, there's no I don't have any bias. I just use that one, and it has been helpful for patients. And then this is a resource from the VA. It's general, so it would be for any patient with ALS, but it's just more of an abbreviated handout on nutrition for ALS and some recommendations. Okay, so adequate intake, we're going to talk a bit more about that. So consuming adequate calories as well as getting enough protein. Okay, so protein is going to be helpful in just maintaining muscle mass, lean muscle mass, the best that they can. So with ALS, of course, they're going to be losing muscle mass. So this is one of the best ways to preserve it, in addition to helping get extra calories. Okay. So protein sources, just kind of as a review, meats, poultry, fish, milk, eggs, cheese, beans, quinoa, nuts, and nut butters can be great sources of protein. And then adding extra calories in general to help prevent weight loss, malnutrition, nut butters, oils, avocado sources, cream sauces, coconut oil, cheese, cream-based soups, cream cheese. So some of those at the bottom are a bit more higher in saturated fat, and I know I sometimes have concern about that. But there is less concern with the ALS population with saturated fats. There was actually a couple studies in the past that said that having cholesterol could be actually protective in some ways. But I don't worry as much about the types of fat in the ALS population. I do see, like, when it comes to nuts, of course, with swallowing, those may become difficult early on, and then nut butter sometimes because of the amount of stickiness. But those are great ways to add extra calories and protein. They are very concentrated in fat, they're and protein and fiber, so they have a lot of benefits for just health in general. But when not being able to eat very much, especially some of these high fat foods on the right here, they can, pack a lot more punch because they have more calories with less volume. Okay, so oral nutrition supplements. We do provide patients with oral nutrition supplements. So it's probably like the least, it's not through a tube feeding. So it's maybe a little less invasive to help prevent weight loss. And about 75% of those with ALS utilize these supplements at some time during the course of their disease. I usually encourage them more so not as a meal replacement, but more in addition. So sipping on these between meals, especially, we don't want it to prevent people from eating their meals, but to enhance what they're eating. So adding extra calories. And, once oral nutrition supplements may not be adequate, this that might be a point where we discuss feeding tube placement. There was a study that looked at whey protein supplementation to be helpful in preventing lean body mass loss in patients with ALS, and then preventing a decrease in their function. And also, there's a study looking at oral nutrition supplements showing that it can help stabilize weight and prevent weight loss prior to PEG placement if they decide to do that. And this can be especially more effective and seen more impact, especially in those with the bulbar onset. So the the type of ALS that impacts speech and swallowing earlier on. Constipation. So I talk a lot about constipation. So there's so many different factors that can contribute to constipation in ALS. It's kind of like a perfect storm when it comes to constipation. So there's less activity typically, less mobility. So even just walking around less, difficulty going to the bathroom alone. So it may kind of prevent people from wanting to go to the bathroom, less hydration. So not drinking as much, not staying as hydrated, difficulty bearing down when you go to the bathroom. So through ALS, it can impact the digestive system and how quickly it empties. So patients may also notice that they're getting full quickly too. And that's kind of that impact of the disease. And then decreased motility. So similar, where it's not that food is moving slowly. And then just eating less fiber, less food in general would often lead to less fiber intake. So some ways to manage constipation. Of course, increasing fiber, but when anyone increases fiber, it's really important to increase the fluid too, or it can have the opposite effect. It can have a more constipating effect. So it's good to do same thing with psyllium. So that's a concentrated fiber supplement. So like Metamucil is psyllium. That same thing, it can be helpful, but you really want to be careful and make sure you get enough fluid, or it can have the opposite effect. Increasing fiber in general. So fruits, vegetables, whole grains, beans can be great sources of fiber in the diet, just to make sure that is included. And I do have patients, I even talk to them about trying to add prunes or prune juice earlier on, just as kind of a preventative to kind of help prevent constipation, or if they're starting to have a little bit of constipation. So about 4 ounces of prune juice, about 3 prunes. So there's, the fiber, but there's also a natural laxative in prunes and prune juice called sorbitol, which can be helpful. Consider a squatty potty like product to help with the assistance in bearing down to go to the bathroom. And then there's of course, medications that can be helpful. So if you're having a hard time managing it with lifestyle, it's okay to add some of the medications. Polyethylene glycol or Miralax is a popular one for ALS patients. Okay, so then there's the question of peg placement. When is it recommended to have a peg placed? And I always talk about, it's completely up to the patient. That we know that peg placement can be important for increasing survival, but not a ton. It's more so the impact on quality of life and getting adequate nutrition. So these are kind of the factors, typically a dietitian and a neurologist or provider will look at to kind of determine when it's best to have a peg placed, if that is the decision of the patient. So a peg is the feeding tube. It goes right into the stomach. Okay, so most, I would say, just about all. I think I've had one that had a tube that went into their jejunum or part of their intestine, but most will go through the stomach. And we look at forced vital capacity. So that is a respiratory function where it's when you look at the ability to completely exhale, taking a big breath in and completely exhale. As that decreases, that can make it more of a risky surgery to have a feeding tube placed, going under anesthesia and such. So that's one thing that's monitored. Dysphagia, of course, swallowing difficulty, weight loss, or if a patient already has a pretty low BMI, or body mass index. So those are, I would say, the biggest one. Taking into consideration negative calorie balance or taking longer to eat meals too. But I would say dysphagia, respiratory function, and weight loss are the big factors we take a look at when recommending peg placement. Okay, and so I've had a good amount of patients that have the peg place but don't necessarily need it. I always say it's like insurance, especially if their forced vital capacity or their respiratory functions declining. So that way that they have it when they do need it, past the time when it may not be safe to have it placed because of the decrease or decline in respiratory function. So these are some products. Again, I don't make any money from any of these, but there's some that are a bit higher in calories, and you may find that those can sometimes be more difficult to administer. Sometimes adding water to them can be helpful. The nice thing about them is they're taking more calories, more protein with less volume. But sometimes it can also make it difficult to get it through the tube when it's too dense. But these are just some examples of formulas. The big difference between this and like an Ensure, technically could go through the feeding tube, but it's not necessarily designed to. Whereas these products really don't have a taste, or a good taste. So it's more of a chalky, where the products for oral nutrition are going to be, taste better. So different ways in which to administer tube feeding. So this is what we call the bolus feeding. So this is, I would say this is the most common way of feeding I see with patients, where they have a tube. Sometimes it's connected if they just have a button at the stomach area, and then you would administer through a syringe. You wouldn't want to push the syringe in like like a typical way you would use a syringe. You would take the top out and just have it kind of go through like gravity. So we don't want to like keep pushing things through, because that can cause some discomfort. So it's also, this is an easy way to supplement. So it doesn't mean you can't eat when you have a feeding tube, or or when you're administering feeding tube, this could also replace that oral nutrition supplement and just be easier for a patient when they're having difficulty getting enough calories in. So that, but this is, I would say, the most common way. The next is a gravity feed. So this is where the formula is administered from a bag that's suspended from an IV pole. And that formula goes through that tube by gravity. So this can be nice if someone doesn't want wants a slower rate of their feeding, like maybe they're getting a bit bloated, just hooking up the IV pole, putting the product or the formula in the bag. And this could be like, hanging out watching TV for an hour during the feeding. Okay. Let's see, anything else I wanted to, yeah. So that I would say is the second most common way in which patients I've worked with receive a tube feeding. And then there's continuous feeding. So this is when it's administered through a mechanical pump to deliver the formula at a specific pressure and a same rate. So I see this more with nocturnal feeding, which means, feeding at night. And that way they can get some extra nutrition at night and then eat during the day. Okay. There may be a reluctance, and I see a lot of reluctance because the continuous feeds, it means you're hooked up at all times. You do want to have the head of bed elevated, so depending on how sleeping goes. But I have seen some success, especially with nocturnal feeds. Okay. So just taking a look at considerations. So in some cases, decision for placement occurs, before it's really needed. So thinking about that, so discussing this early on can be helpful. And then it can provide not only nutrition, but it can also provide fluids. So especially if someone's having difficulty getting enough water, that, and maybe they had their feeding tube placed before they need it, they could use that also for hydration or medications if they're having trouble administering medications. It doesn't mean you can't eat by mouth if you have a feeding tube. You can definitely do that. And then kind of considering there's pretty low maintenance now as far as keep taking care of a feeding tube. I want to touch on hydration. So hydration is going to be important no matter what, if you're eating by mouth, if there's a combination, or if you're receiving tube feeding, but kind of paying attention to signs and symptoms of hydration. A big one that I have patients like monitor the color of their urine, making sure their skin's not too dry. And then, reviewing water flushes. So typically with a tube feeding, you're going to want to flush before and after each feeding. And then you could also provide additional water in between as well. And then sometimes there's what we call the free water protocol. In most cases, if someone is recommended to thicken their liquids, typically it's okay to drink water. I would, of course, touch base with your speech pathologist or your physician, but typically it can be okay to drink water in between meals as long as the patient with ALS has good oral care. Because the idea, like I talked about that aspiration pneumonia, the idea is that if water were to go down, if you were to aspirate water alone, it would likely evaporate. But if you were to bring down food particles with it, that's when it could be an increased risk for aspiration pneumonia, creating, because that bacteria can grow. So that can be, a thought as well. Sometimes if someone's recommended to thicken their liquids, they would want to thicken everything but water, or they could thicken everything but water in most cases, unless water is consumed with the meal or with food. Okay. And then some other PEG placement considerations, of course, respecting the individual's decision. It is completely up to them. But I do like to make sure that they know that it is not a form of life support, more for comfort, adequate nutrition, when that adequate nutrition can't be obtained by mouth. It typically won't get in the way of everyday activities. They're very discreet now. A lot of times they have buttons. You can barely tell that they're there. You can still eat by mouth, like I mentioned earlier, and it can really promote quality of life. And then another topic is end of life nutrition. So and this can be, of course, a very tough time, but at that time, tapering down on the amount of tube feeding, just making sure that patient is comfortable. I still have in here veterans' wishes, providing adequate nutrition, and then encouraging comfort eating as desired, as well as the enteral nutrition, or through the feeding tube is enteral nutrition. Okay, so here is my contact information. And this was a picture years ago. This is an old picture. My son's now 10, so you can say how old that is, but one of our pictures at the ALS walk. And then I have some references too. But I think we have hopefully some time for questions.
Erin, thank you so very much. Thank you. Yes, so guys, if you have any questions at the bottom, well, mine's at the bottom, yours might be at the top of your screen. That Q&A feature will be able to put your questions in there, and we will let Erin answer away. So we'll see if anybody has any questions.
I was gonna say, I'm having a hard time finding it, so if you don't mind.
It's on mine. It's on
Okay.
mine. So I'll read the
asking.
questions if they pop up. Right now, there aren't any, and I'll make sure. Yeah, okay. Leave it closed until. So now's the time, guys, to ask any questions that you may have. So now, how old did you say your son is now?
He's on 10, almost 11.
Yeah, that is an old picture.
But I like that one. And I'm, look, almost 10 years younger there.
Here we go.
And my husband had hair.
So, Brenda asked if you could put back the ALS website for more information.
Does she mean the slide maybe?
Yeah.
That had the ALS. Here, let's go.
There you go.
So yeah, so those nutrition.va.gov is where I found, that's where our resources are, but in most cases they're not specific just to veterans, but they're free sources of education. And then that's the easy to swallow, easy to chew cookbook too, in addition to the ALS resource.
So I have a question here about someone missed part of the beginning. Can they see the website? Yes, this website is being this presentation is being recorded, and it give me a couple days, but what I will do is then we save it. We have a YouTube channel. You can look at it at any time. Reach out, John, if you know your care service coordinator's name, and tell them that you would like a copy of it, because what I do is I send them a copy of all of the ones, and this will be added to it, and you can click the link and watch it whenever you want. Okay, see if we have any other questions. This was really thorough, so it doesn't surprise me that we don't have a lot of questions, because this was very thorough with a lot of examples and things. Okay, we will wait just a few more minutes to see if anybody is typing away at any questions. I don't think I am missing. No, I'm not. Make sure, check the others. Yeah, there we go. Okay. So while we're doing, oh, here we go. Oh, great
No, thank you.
presentation, Erin. Thank you very much, is what was typed in here. So I second that. I second that notion there.
Oh,
So
thank you.
while if anybody else is typing any questions, let me all tell you, as I said before, all of our and there is a question. So all of our webinars are archived. If you're interested, let your care service coordinator or reach out to someone at your location and say, hey, can you send me the list? And you can have the list, watch them anytime you want. As far as a webinar in December, I'm waiting for the person to send me some information. We're getting real close to the cutoff time, so that might be shifted to January, but you'll get links and everything. So the next question is, we're getting a couple now. Can muscle mass return after tube placement and proper nutrition?
So the tube placement, I'm guessing after, a feeding tube placed and maybe they're getting better nutrition, it sounds like. I wouldn't say it can really return. It's more so the disease progression that's impacting the muscle mass, but it can help decrease the decline in muscle mass and help preserve at that point. And it can, it's protective to have those extra calories, have that extra weight, even if there is, if you're unable to return to that previous muscle mass and then are there any foods we should
Oh,
avoid?
you can see it.
Yeah, I can now.
Okay.
I don't, not necessarily, uh, like in general, but as of course the diet progressing goes and noticing any foods that you may feel like you aren't tolerating, I typically recommend people avoid those, but I can't think of a certain food anyone should avoid altogether in general. But sometimes people especially have a harder time with really hard foods, like nuts. Sometimes actually bread can be difficult because it creates that bolus. So that can be sometimes difficult to swallow. Stringy foods, foods that increase saliva production, like really sour foods, things like that can be difficult. But not, I would say typically that's going to be on a case by case basis, see how you respond to the different foods first.
So what's your take on rice?
I don't have much. That rice can be okay, but you're right, sometimes it can be a food that may be more difficult. So if you do rice and you're starting to have difficulties, making sure there's a good sauce on there.
There's one
Okay,
more. I don't know if you want me to read it or if you can see it.
I can read it. Why does weight
Okay.
go to the stomach area? You know, so because of I'm actually not positive on this one. Um, but I don't think there's really anything to help it not happen. But I know, partially they're losing that muscle mass and the extra, the fat stores just tend to accumulate around the abdominal area. But unfortunately, I know it can be really uncomfortable for people, especially as they have that change in body composition. Because of course, we typically notice it the most around our abdominal area too, and it almost feels like they're gaining weight, but a lot of times they're not. There's a change in body composition, so they're less muscle mass and more fat mass, even though they may actually be losing weight during that time. Whoops.
Yeah, I thought I did. I was scrolling
No,
down.
you
I
did
thought I
that.
did that for a second. Um, so we're going to wait 1 or 2 more minutes to see if we have any other questions so we don't miss anybody's questions. And I think we're pretty good.
Okay, so I see before ALS, I intentionally lost weight from 250 to 210. Since I know I've regained 10 to 15, but it's not muscle. Yeah, and even if it's not muscle, it still can be protective. So I would say, um, if you're comfortable with it, if you can try to hold on to those 10 to 15 extra pounds, that would be beneficial. And yeah, I typically don't worry about intentional weight loss before diagnosis. It's more so that unintentional.
Then there's a question about how about a glass of wine?
Oh, I don't say anything, I say, it's completely up to you. You can have that anything you want. I would say, just kind of paying attention if it's preventing you from eating as much, if you're noticing that, you're drinking a lot of alcohol, but one glass of wine, it's fine. I did have one patient, this actually reminded me. He was, he was a big drinker. He drank a lot of, I'm trying to remember which beer it was. I think it was some type of light beer, like a natty light or natural light or something like that. And he came back to the next appointment, and he was so excited because I talked to him about getting extra calories. He switched from natural light to blue moon. So he was getting
Yeah,
extra calories, but
he was
probably not from the best source.
he was following your instructions there, following your instructions. Okay, Paul, I'll answer that one. So what I do is I actually download this to the YouTube video, but it give me a day or so, because the person who actually helps me do it, because the last time I did it by myself, I did it wrong. So I steal someone else's brain to do the download. And so give me a couple days, but we can then send you out. I'll make sure that you get a list of the webinars and the links to them. And like I say, anybody, we have a YouTube channel that you can go to that specifically has, it's got everything, every YouTube thing that we do as a territory, but I can give you the links. The webinar listing will give you the links specifically to a specific webinar, so you don't have to look around for it, but we'll make sure you get that. And I'll let you answer this one.
Okay. I'm down 60 pounds and can't gain weight if I don't fix it. So, John, I would say, nothing necessarily happens that, if you don't already have a feeding tube. I would, if you're willing to, this would be a good time to have that placed. I would say at this time, just really trying, if you're unable to gain weight back, just really trying to prevent any further weight loss. And depending if you're, what you're able to eat, trying to add some of those extra calories. If you're not on an oral nutrition supplement, that can be helpful. And monitoring your weight pretty frequently if you're able to safely get up on a scale once a week, just to kind of keep an eye on things. But just trying your best at this point to prevent any further weight gain. And if you can gain weight, that's a bonus.
All right. Well, it looks like we are out at the end of our time. Erin, thank you so very much. As I said at the start, nutrition is so important, and it's questions that people have, and you answered them all, and I really appreciate it. And to everybody who came on board today, once again, I appreciate your support of our webinar series here at the Mid-Atlantic Territory. And if you have any ideas of what you'd like to see on a webinar, let your care service coordinator know, and we will see what we can do to make that happen. So if I say to everybody, happy Thanksgiving. It seems early this year, but it's right around the corner. So as we go into the holiday season, happy Thanksgiving. You all be safe. And Erin, Once again, thank you so very, very much.
Yeah, thank you for having me.
All
That's
right.
great.
Thanks,
Great
guys.
questions.
See you later.